So getting started, APCM is because it has all this all these different service elements. It ends up being this interesting interplay between what the practice does, what the EMRs do, but no EMR, EHR has all the things needed yet, at least from what we've seen, and we have pretty good visibility into it, to do all the things that are now required by APCM. Some of them you could do sort of manually outside the EMR. You don't necessarily need a platform for this. It's not necessary. It's not like some services that sort of say you have to have something explicit, and it could be done technically through an EMR system. That said, there's a lot of different aspects to this that one have to be recorded in ways that EMRs aren't necessarily well suited for. But two, that when you're doing this at scale, at a patient population level where you have 500 to 1,000 to 4,000 patients doing these services, EMRs just haven't been built for that yet. They surround around sort of the visit encounter structure, and that is less feasible when you're dealing with huge scaled programs like this. So that's where platforms come in. And there's quite a few that are, maybe not quite a few, but there's a few that are being built and being tested now and sort of have been released recently. And so I kind of wanted to at least give an idea of where the different requirements sort of fall as far as responsibility and sort of and how they can be managed. And I will say that this might change over time, right? As EMRs change. And it might change depending on the EMR you have. But the idea is you have certain things that the platform does, right? Consent, the care plan, activity tracking, insights into care gaps, basically the things that are explicit to APCM that are not sort of day-to-day stuff done on the EMR. And then you have other things like the initiating visit and the EHR performance measurement stuff. The EMR has to be an ONC certified EMR that has to go through the EMR. And then you have these things where they're kind of in the middle and they're shared, right? Your EMR might have good digital communication services, but it might not at the scale that you have it, right? Is it just a televideo appointment that you have to put a schedule, a appointment in the schedule? Or can it be this more, laissez-faire or a little more casual messaging, right? Where it's not an instant message that they get right away, but all these different things are going to be an interplay between APCM platforms, the EMR, and then sort of a shared mix of integration between the two. Quick example of what this looks like, right? And I won't spend too much time on this, but the idea here is you have to have some amount of identity. You have to have the population level metrics, right? And your APCM platform may or may not have that. The good ones are going to be importing it in, which I believe that they should be imported into a lot of this, from a population level. But a lot of folks are already doing that on the EMR, right? So identifying, enrolling, probably on the APCM platform, the attesting that you're doing all those service elements is really, really important. They just announced that they're doing more audits on some of these other care management services, including RPM. This is the way that this has been described so far, and sort of the requirements that they've released so far are done in a vague enough way that there's going to be oversight of this and making sure that you just sort of, in good faith, have the 13 elements is important, right? So having that attestation, but also having the documentation where if there's ever a chart check or an audit, God forbid, you have all the information, you hand it to them and say, doing all of it, right? Then off you go. Care plans, comprehensive patient centered care plan, document all the interactions, and then do the billable codes to be in the platform. And then, of course, you have, the other care coordination and code and billing and things like that. So again, interplay between the two is I guess, the takeaway here. And your mileage may vary a little bit as far as what's in the blue and what's in the orange, but there's going to be an interplay between the two, at least for the foreseeable future. I mean, EMR systems are just now starting to get good, fairly good CCM programs, and that thing's been in for, over 10 years now. So yeah, take some time. APCM is also outsourceable. Not entirely outsourceable, because there has to be general direct supervision and the practice still needs to be the one that's billing for the services. So basically you're hiring agents, right? They're contractors, but if you're hiring a company as an agent of you to help furnish the requirements. So you have a sort of a decision that you can make, right? Do I want to do let's say I want to do my whole patient population, which that's what these things are meant for, right? Is you're doing it at a population level. I can have MAs and my, my nurses and MAs and clinical staff manage all of it, right? The problem with it's not even a problem. If it's something you want to take on, it is the best solution for the patients if you're doing it in earnest and really building it out, right? To have it in-house and close to chest. That said, there's a lot to it. There's a lot to the documentation of it and making sure that a patient got the thing when they asked for the messaging, that it went the right way, and the care plan and doing the care planning and the updating and making sure the patient has access to it. There's a lot to it. So it's not like CCM where you outsourced it and it would be 20 minutes of talking, but there's going to be some amount of talking and there's going to be some amount of care management time spent on all of these patients. You can't just bill for this and not do the underlying services, at least a fair percentage of the time, right? If they look and you say, yeah, CCM was, care management was available. We talked to them, they have a phone number, and no one answers that phone number. That is the sort of thing that will get you in trouble, even when this is early and sort of in flux. So having an outsource makes that relatively easy. So if you're the kind of practice that didn't want to deal with CCM because it seemed like too much of a lift and paperwork and calling, APCM is a great place to push that onto a third party vendor. Some are better than others. Some are more legitimate than others. I highly recommend you do your diligence. I'm obviously biased as to who you should choose. That said, outsourcing makes a lot of sense, and CMS has been explicit that this is the kind of thing that can be done under general supervision, and you can outsource it that way. And then you can have the hybrid between the two, right? Where they do some internal and then some hybrid with the third party. So you have a trade-off with reimbursement and workflow. The ones that are pure outsource, wash your hands of it. The best programs are either hybrid, where you have major coordination between the office and sort of the outsourcing company, where the outsourcing company does 90% of the work and you guys do, the office is 10% of the work. But you can, you can sort of choose what that looks like depending. Before Q&A, quick, I just said that I'm biased and this will prove it. Quick talking about us, what we do. So we are both a software platform and also outsourcing vendor that we also provide devices. And we're very, very excited. I actually, prior to this call, was going through some of the beta testing that we're doing to announce an advanced primary care management module, right? Ironically, a lot of the services that we do are, when you do want to do APCM, are bundled into it already. And we'd love to show anyone, schedule a demo or anything like that to show you how we can really provide some value going forward on this. We're excited about these codes. And yeah, we'd love to talk about that with anyone individually as well.